We tend to think of drugs in terms of intensity, stronger versions of familiar experiences. But fentanyl isn't just more morphine. It represents a fundamental break where the margin between effect and lethality collapses to a point that no longer accommodates human error, genetic variation, or even the time it takes to realize something is wrong. Developed in 1960 for cardiac surgery anesthesia, fentanyl succeeded at providing profound pain relief without crashing blood pressure. But the same molecular architecture that made it a medical breakthrough, extreme receptor affinity, rapid brain penetration, and a structure so flexible it spawned thousands of variants, has rendered it uniquely lethal outside controlled settings. This is about what happens when high-precision pharmacology collides with biology that hasn't changed in millennia, and economic forces that select for concentration over safety. Most opioids trace their lineage to the opium poppy's phenanthrene scaffold. Fentanyl belongs to a different family, the 4-anylidopyperidines. This structural difference determines how the drug fits into the mu-opioid receptor, the protein that regulates pain, reward, and breathing. While morphine occupies the receptor's entrance, fentanyl moves deeper into the binding pocket. It establishes an ionic bond with aspartic acid residue ASP-147 plus a crucial second interaction with histidine residue His-297. This molecular handshake gives the drug sub-nanomolar binding affinity. Vanishingly small quantities trigger maximal response. Carfentanil, a fentanyl analog, binds at 0.02 nanomolar. That's roughly 10,000 times more potent than morphine. The flexibility of this chemical structure creates what chemists call a vast chemical space. Modifications generate compounds like sufentanil and alfentanil, each with different potency and duration. This same flexibility that makes the structure valuable in anesthesia also makes it trivially easy to synthesize in clandestine labs. When fentanyl binds to the receptor, it triggers G-protein dissociation. One subunit inhibits adenylyl cyclase, dropping cyclic AMP. Another acts on ion channels, closing calcium channels, opening potassium channels. This hyperpolarizes neurons, inhibiting their firing, the basis for both analgesia and central nervous system depression. But receptor binding is only the beginning. Fentanyl's octanol water partition coefficient exceeds 700. This extreme lipophilicity allows it to cross the blood-brain barrier in approximately 5 minutes, effectively instantaneous onset. In clinical settings, this rapid action is followed by short duration, typically 1 to 2 hours after a single dose. But this offset isn't metabolism, it's redistribution. The drug moves from brain tissue into peripheral compartments, muscle, then adipose tissue. With controlled dosing, this creates predictable pharmacokinetics. But with repeated supratherapeutic doses, the pattern with illicitly manufactured fentanyl, redistribution becomes a trap. Adipose tissue acts as a massive reservoir. For people using fentanyl regularly, the drug accumulates over days and weeks. What was classified as ultra-short-acting becomes functionally long-acting. Clinical studies detect fentanyl in urine for an average of 7 days, with some cases extending to 26 days. Higher body mass index extends this sequestration. The clinical consequence is profound. While buprenorphine, used for addiction treatment, can typically be given 12 hours after heroin use, attempting the same with fentanyl-exposed individuals triggers severe precipitated withdrawal. Slow, persistent release from fat stores keeps receptors occupied. When buprenorphine displaces residual fentanyl, it causes a sudden drop in opioid signaling. Standard protocols built on heroin pharmacokinetics don't apply. This is a drug whose behavior changes with exposure pattern. The body becomes a time-release mechanism with no off switch. Fentanyl's lethality is typically attributed to respiratory depression, suppression of the brainstem's drive to breathe through mu-opioid receptor activation in the pre-Boettinger complex. Neurons hyperpolarize, reducing responsiveness to rising carbon dioxide. Breathing slows until it stops. But there's a second mechanism, not mediated by opioid receptors at all. Fentanyl-induced muscle rigidity, known as wooden chest syndrome, causes sudden stiffening of skeletal muscles, thorax, abdomen, larynx, jaw. Recent research identified the cause. Fentanyl directly blocks ether A-GoGo potassium channels, specifically Kv10.1 and Kv11.1. These channels are expressed in cervical spinal motor neurons that innervate the diaphragm and respiratory muscles. Normally, they inhibit electrical excitability. When fentanyl blocks these currents, it creates paradoxical excitation, recruiting tonic motor units and causing persistent contraction. The chest wall becomes so rigid that bag valve mask ventilation is physically impossible. Vocal cord closure often accompanies this, creating total airway obstruction. And because this operates through non-opioid channels, naloxone is often ineffective at reversing the rigidity. This explains naloxone-resistant overdoses where patients exhibit continued chest stiffness and airway obstruction even after multiple doses. Fentanyl doesn't just stop the signal to breathe, it can mechanically prevent breathing even when the signal returns. As more people survive overdoses, a new phenomenon has emerged: opioid-associated amnestic syndrome, dense, permanent anterograde amnesia, inability to form new memories from hippocampal damage. The hippocampi are essential for memory consolidation and among the most metabolically demanding brain regions, making them selectively vulnerable. MRI scans show symmetric bilateral diffusion restriction indicating acute cellular damage. Two theories explain this. First, straightforward. Hypoxia during respiratory depression causes ischemic damage. Second, more unsettling. Rodent models using fully oxygenated subjects suggest fentanyl may inhibit GABAergic interneurons in the hippocampus, cells that break excitatory activity. The resulting disinhibition creates a storm of excitatory signaling that drives hypermetabolism and neural death. Some cases also involve cerebellar and basal ganglia damage, causing severe cognitive and motor impairments, requiring months or years to partially resolve. This is not a complication, it's an outcome. And it's only visible now because survival rates improved enough to reveal what happens after resuscitation. Chronic fentanyl exposure systematically degrades homeostatic systems in ways that remain invisible until significant damage accumulates. Opioids disrupt the hypothalamus-pituitary axis. Chronic use suppresses gonadotropin-releasing hormone, reducing luteinizing and follicle-stimulating hormones. In men, this causes dramatic testosterone reduction in 19% to 86% of long-term users, sexual dysfunction, muscle loss, fatigue, depression. In women, reduced estrogen and DHEA, menstrual disruption, infertility, early menopause. 9 to 29% develop adrenal insufficiency. HPA axis suppression, so profound the body cannot produce sufficient cortisol. This causes muscle aches, nausea, dizziness, and potentially life-threatening adrenal crises during stress. Up to 50% of men on long-term opioids develop osteoporosis or osteopenia. The immune system, expressing opioid receptors on nearly every cell type, shifts toward immunosuppression. Chronic users show higher susceptibility to infections, reduced vaccine response, slower wound healing. Some evidence suggests chronic use may facilitate cancer progression. This isn't addiction, it's metabolic dependence. The body reorganizes around the drug's presence. The crisis has been complicated by xylazine, a veterinary sedative increasingly mixed with fentanyl. Xylazine is an alpha-2 adrenergic receptor agonist, creating pharmacological synergy with opioids. Both suppress respiration through distinct pathways. Fentanyl acts on mu-opioid receptors. Xylazine activates alpha-2 receptors. The result is additive suppression of heart rate and blood oxygenation. Naloxone only reverses the opioid component. The alpha-2 mediated respiratory depression remains. Patients may regain consciousness but remain profoundly hypoxic and sedated. Preclinical studies show combining naloxone with atipamezole, an alpha-2 antagonist, can restore breathing, but atipamezole isn't approved for human use and causes cardiovascular instability. The crisis is no longer single drug. It's multi-agent poisoning requiring interventions that don't exist in emergency protocols. Fentanyl's market dominance wasn't driven by user preference. Many report fentanyl's high is shorter, less euphoric, and more dangerous than heroin. The transition occurred because of the iron law of prohibition. When enforcement increases trafficking costs, it creates economic pressure for maximum concentration. 1 kilogram of fentanyl equals 50 to 100 kilograms of heroin. This makes it vastly easier to conceal. The pattern appeared during alcohol prohibition, when beer and wine were displaced by hard liquor. Enforcement doesn't reduce supply, it selects for potency. Following China's 2019 fentanyl ban, manufacturers shifted to uncontrolled precursor chemicals shipped to Mexico, where cartels convert them into millions of counterfeit pills. The supply chain adapted. The drug concentrated further. This is economically inevitable. Prohibition creates selection pressure for the most dangerous variant to dominate. While the illicit crisis dominates the narrative, the pharmaceutical industry's role in normalizing ultra-potent fentanyl formulations is rarely examined. Transmucosal immediate-release fentanyl products were developed strictly for breakthrough cancer pain in opioid-tolerant patients. Aggressive marketing changed that. A 2005 study found 90% of active prescriptions were off-label, with only 10% of patients having cancer or AIDS. In France, 51.8% of prescriptions were off-label, often for rheumatologic or neuropathic pain. This normalized immediate-release, high-potency opioids outside palliative care. When prescription oversight tightened, a habituated population turned to illicit supply. The crisis didn't begin on the street. It began in clinics. Fentanyl represents the convergence of molecular precision, economic inevitability, and systemic failure. Its extreme receptor affinity and off-target ion channel effects create dual-mechanism lethality. Its lipophilicity transforms single-exposure pharmacokinetics into weeks-long sequestration. Its market dominance is the predictable outcome of enforcement selecting for concentration. And its normalization began in pharmaceutical marketing. The evidence reveals something uncomfortable. This isn't a problem of individual choices. It's a biological and systemic trap where molecular structure, adipose sequestration, prohibition economics, off-label prescribing, and polysubstance synergy reinforce each other. Understanding mechanisms doesn't provide easy solutions, but it clarifies why simple narratives fail and why interventions designed for earlier eras no longer match pharmacological reality. Fentanyl doesn't give second chances because it was never designed to operate outside environments with ventilators and trained anesthesiologists. It escaped that context, and the body, which hasn't changed, is paying the cost. If you're still here, thank you for being part of this journey. Subscribe to stay tuned for what's next.